Deletions and Modification to Diagnoses. We are thrilled to have Dr. Schraufnagel here with us today. For a brief introduction to Dr. Schraufnagel, here we have the evidence-based treatment of anxiety disorders has been Dr. Schraufnagel's long-standing and predominant clinical interest. He has substantial experience treating obsessive-compulsive disorder, panic disorder, post-traumatic stress disorder, generalized anxiety disorder, and social phobia, and is facile with both protocol and principle-driven approaches to treating these disorders. Dr. Schraufnagel has also garnered experience treating these anxiety-related disorders in the presence of depression, substance use disorders, and other mental health problems. Dr. Schraufnagel earned his PhD in clinical psychology from the University of Washington, which is where he completed his undergraduate degree in psychology as well. His research focus in graduate school was on adult male survivors of childhood sexual abuse and the mental health and behavioral correlates of such experiences. Dr. Schraufnagel completed his predoctoral clinical internship at the VA Puget Sound Healthcare System, Seattle Division. Finally, he is a member of the Association for Psychological Science, the American Psychological Association, the Anxiety and Depression Association of America, the Association of Behavioral and Cognitive Therapies, the International OCD Foundation, and Psychologists for Social Responsibility. Trevor Schraufnagel, take it away. Thank you.
Okay, will do. Thank you, Louisa. Thank you for the flattering and thorough introduction. And thank you to Valen for hosting the webinar, and thank you to all of you for joining me. A couple things I'd like to say before I get started here. Excuse me. The first is that there's a fair amount of debate in the changes that have taken place, certainly across the DSM-IV, but also within anxiety disorders. Okay, so what I want to do is, I guess, introduce the fact that the presentation today is going to center around what the changes are. Okay, that is to say, what are the anxiety disorders that are included in DSM-IV, and then what are the changes to the ones that have been kept, what's been added, what's been taken away. What I'll refrain from doing is entering into the debate about the decisions that were made by the committees in the DSM-IV with regard to what's included and what's not included, or where things have been moved around. Okay, so if we do a Q&A at the end of the presentation, if we could focus on what the changes were rather than why they were made, that would be helpful. We just don't simply have enough time to get into the debate today. Secondly, it's important to know moving in that there's a lot of text on most of these slides. It was a little bit difficult to organize because in some cases things were omitted, in some cases things were added, in other cases things were changed. So I chose not to animate the slides and have the criterion enter one by one for sake of time. So when I switch to a new slide, it's kind of a flood of information. And I'll walk you through the information, but please do bear with me because it's going to be an unusually large amount of text per slide. That said, we'll move along. Okay, so before we dive in to discuss the details of DSM-V, I guess I just want to review what the anxiety disorders were in DSM-IV. Okay, we had panic attack, panic disorder with and without agoraphobia, agoraphobia without a history of panic disorder, specific phobia, social phobia, OCD, PTSD, and acute stress disorder, GAD, and then anxiety disorder due to general medical condition, substance-induced anxiety disorder, and then anxiety disorder not otherwise specified. So that list now looks like this. We now have separation anxiety disorder, selective mutism, specific phobia, social anxiety disorder, panic disorder and panic attack, agoraphobia, GAD, substance or medication-induced anxiety disorder due to another medical condition, other specified anxiety disorder, and unspecified anxiety disorder. Okay, so some key omissions. PTSD, acute stress disorder, and OCD all were included in the anxiety disorders, and they've all been omitted from the current anxiety disorder section. In general, this is for the same reason. That is to say, these disorders have more in common with themselves, and now PTSD and acute stress disorder are included with stressor or trauma-related disorders, and OCD is its own section, obsessive-compulsive and related disorders. So the committees believed that these disorders have things that are more similar to one another than with the other anxiety disorders. In the case of PTSD, it was largely believed that it's more heterogeneous than the other anxiety disorders because it often includes changes to worldview and depressive features that are somewhat unique to trauma and stressor-related disorders and differentiate them from anxiety disorders. A couple different diagnoses have also been added for DSM-5. The first one, separation anxiety disorder, was included to better account for the fact that the same symptoms and the same problems are seen in adults, not just children. Both of these two additions were formerly included in diagnoses, disorders usually first diagnosed in infancy, childhood, or adolescence. But to allow the incorporation of adults, separation anxiety disorder has been moved into the anxiety disorder section. Selective mutism, also now added to anxiety disorders, although it's somewhat hard, it was hard for me to find the exact and precise reason for the inclusion. All I could find within the DSM or elsewhere was the fact that the vast majority of kids with selective mutism are anxious. And then there's a key absence. So in DSM-IV, there was a disorder that I'm sure we're all familiar with called hypochondriasis. Hypochondriasis no longer exists. What used to be known as hypochondriasis is now known as two different disorders. One of them is somatic symptom disorder, and one of them is illness anxiety disorder. So it's obviously counterintuitive to include something called illness anxiety disorder, but not to include it in the anxiety disorder section, but that's in fact what's taken place. It's included in the somatic symptom and related disorders section. The idea behind this was that 75% roughly of those that would have met criteria for hypochondriasis will now meet criteria for somatic symptom disorder because they do have anxiety, but they also have somatic symptoms and somatic complaints. It's assumed that 25% of the people that would have been subsumed by hypochondriasis will now meet criteria for illness anxiety disorder because they have significant worry and concern over somatic problems, but they don't have any somatic problems per se. Okay, now we'll move forward into the anxiety disorder diagnoses within the DSM-5, and we'll move through each of them in turn, discussing the changes that have been made. Before we do that, however, I guess I want to stress a few of the differences in style between the DSM-5 and the DSM-IV. One of them that I think is very nice is that the diagnostic criteria for each disorder now are provided at the outset of the section. If you remember back to DSM-IV, you would turn to the page where the diagnosis began, but you wouldn't actually get the criteria for the diagnosis until 2, 3, 4, 5 pages later, and you had to search through. Now they're provided immediately upon the beginning of the section. Okay, the anxiety disorders in DSM-5 have also been ordered by typical age of onset. So we begin with separation anxiety disorder, move to selective mutism, and then on from there. There's also in DSM-5 a greater distinction between the criteria. There were different cases. I think social phobia was the best example, where the criterion A in social phobia was actually 2 separate criteria. Those have now been separated, and this has happened throughout the diagnoses, and in my opinion have cleaned this up a little bit so that each criterion just references one requirement of the diagnosis. DSM-5 also stresses a typical duration, okay, a typical duration of the disturbance, and it allows for greater sociocultural emphasis and accommodation. I think by doing this, DSM-5 allows for greater precision without greater restriction. There are certain cases that I'll highlight where typical duration of symptoms is stressed so that if someone has a problem that's been going on for 5 months and 20 days, you don't have to not give them the diagnosis because they haven't reached the 6-month mark. So it allows the clinician to make a judgment about the clinical course and whether this is atypical or typical. There's also a more uniform definition across diagnoses of distress and impairment. The statement that I'll allow you to read there at the bottom is basically used across all disorders. This wasn't the case in DSM-IV, where the distress and impairment feature was included across the board, but it was worded differently and varied substantially between diagnoses. This is no longer the case, and I think it makes it quite a bit more simple for us. Finally, in DSM-IV, I think they did a very nice job of highlighting the importance of distinguishing between fear and anxiety. Okay, so it's described that fear is an emotional response to a real or perceived imminent, emphasis on imminent, threat versus anxiety, which is anticipation of a future threat. And that when we think about fear, we're thinking about substantial autonomic arousal and a desire to escape. Anxiety is more associated with tension and action urges to avoid future potential dangers. These two sentences were taken right out of the beginning of the anxiety disorder section of the DSM-IV. I think this is a real attribute of the new version. Okay, so let's start with separation anxiety disorder. As I already mentioned, separation anxiety disorder formerly was included with diagnoses usually first made in infancy, childhood, and adolescence. It's now incorporated with the anxiety disorders to allow the incorporation of adults. Okay. So if we look at criterion A, the biggest difference in criterion A is that it no longer mentions home. Okay, it used to talk about separation from home or from those to whom the individual is attached. In DSM-V, the emphasis is clearly on attachment figures, okay, not about being away from home. It's not homesickness. It's kind of attachment sickness. Now, the symptoms, I have a few of them listed in criterion A, are the exact same symptoms, but the wording has been changed in DSM-V to allow the inclusion of adults. Okay, so in most cases, I think the stereotypical attachment figure is a parent or a caretaker or another adult for a child. DSM-V wants to emphasize the fact that this could actually be another adult. If you're an adult, it could be a partner or a spouse or a loved one. It could also be your children. In criterion B, it used to just rest upon 4 weeks in children because the inclusion of adults was not considered. It would not have been appropriate to make the diagnosis for an adult. There was nothing about 6 months that was referenced in DSM-IV. Okay. Then we have C, distress and impairment, and D, that it's not better explained by another mental disorder. With regard to selective mutism, this is exactly the same as it was in DSM-IV. The only difference, again, is that it's now found in the anxiety disorder section and no longer in the diagnoses that are made typically in infancy, childhood, or adolescence. So we have a failure to speak in specific social situations, okay, in which there's an expectation of speaking, and the person speaks in other situations. Okay? It interferes with educational, occupational. It's lasted at least a month. Failure of speech not attributable to a lack of knowledge of the language, and it's not better explained by a different communication disorder. With regard to specific phobia, okay, again, this is one that was obviously included in DSM-IV. It remains an anxiety disorder in DSM-V. A and B are largely the same. Okay. C stresses the importance of active avoidance or enduring the stimulus with intense fear or anxiety. And the real change for specific phobia comes in at criterion D. Criterion D stresses that the fear or anxiety is out of proportion to the actual danger. Okay. Now that used to be an item that stressed that the person sees the fear or anxiety as excessive. It no longer requires that they consider it excessive. Knowing what we know about anxiety disorders, we know that people are anxiety or have difficulty managing anxiety are disproportionately likely to overestimate threat. So to sort of allow them to interpret the appropriateness of the level of threat is somewhat at odds with what we know about the clinical condition. So now that responsibility lies with the clinician to judge whether or not it's out of proportion to the danger and to the sociocultural context. Fear or anxiety is persistent, typically lasting 6 months or more. Okay. So again, we have a reminder that there's not a strict cutoff of 6 months, but what we're looking for is not transient symptomatology and instead a fairly durable fear, anxiety, and avoidance. F obviously states there's distress and impairment, and that it's not better explained by another mental disorder. In DSM-IV, there were these same categories of phobias: animal, natural environment, BII, blood injection, injury, situational phobias, and then other. In DSM-V, the term has been changed from a subtype, which it was in DSM-IV, to a specifier. Okay, so it's a slight change in term. And it's also important to note that if a person meets criteria for more than one specifier, more than one type of phobia, they'll get a separate code. The codes I don't have included here, but they would get a separate code for each specifier. Okay. Now we'll move towards to social anxiety disorder. Social anxiety disorder, though, has been separated. This is one area where A and B have been separated now into two items, when formerly in DSM-IV they were included in the same item. A states that there is this marked fear or anxiety about one or more social situations in which the person is exposed to possible scrutiny. The emphasis is on scrutiny and on social evaluative opportunity. In DSM-V, you can see under that first arrow where it says examples include social interactions, etc. It specifically says unfamiliar people, and it specifically says performing in front of others. Those are now highlighted as potential spots in which social anxiety would be evidenced. In DSM-IV, that was actually in the main body of the text and was more emphasized. Now it's been kind of de-emphasized and just giving it as a list of examples. In B now, the individual fears that they'll act in a way to either show anxiety symptoms or that will be negatively evaluated, that they'll be humiliated or humiliate themselves, or lead to rejection or offend others. That last part, will lead to rejection or will offend others, is important and often overlooked manner in which sometimes social anxiety disorder is evidenced. I'm going to move slides now. Looking at criterion C, by and large, criterion C is the same. By the way, in many cases now, this same type of criterion where it says almost always provoke used to read will invariably provoke. So there's a slight wording change, although I don't think it's very important. The social situations are avoided or endured with intense fear or anxiety. And again, the fear or anxiety is out of proportion. Okay? So again, we're not relying on the person with the social anxiety to determine whether or not the fear or anxiety is excessive. It's up to the clinician. It's up to the clinician to decide if this seems like it's out of proportion to the actual threat and out of proportion given one's sociocultural context. Again, typically lasting 6 months or more. Okay, so there's no black and white cutoff. There's kind of a target, but it allows for some variability and clinical judgment, which I think serves us well. Finally, with social anxiety disorder, it obviously needs to cause clinically significant distress or impairment. Okay? It's not due to the effects of a substance or a medication or a medical condition, and it's not better explained by another mental disorder. However, if another medical condition is present, the symptoms are unrelated or excessive. And again, this is in the judgment of the clinician. Okay? Two things I want to emphasize here. One is that this is the first place in which we see the term if another medical condition is present. You'll see that throughout the new DSM, that kind of wording wasn't present in DSM-IV, and I think it represents a subtle shift towards a greater appreciation of the biological contributions of mental disorders. Beyond that, a person can meet criteria for social anxiety disorder even if they are disfigured. Okay, so if someone experiences a lot of social anxiety and it centers around being disfigured in some way, it's still possible that they could get the diagnosis if the symptoms are excessive or out of proportion. Okay. Finally, there's a new specifier. If you think back to DSM-IV, the specifier was whether it was generalized or not. Now it's been reversed. So instead of specifying if it's generalized, we specify if it's performance only. So public speaking phobia would essentially now fit under this category of social anxiety disorder, performance only. I'm going to move to the next slide. Panic attack. So panic attack isn't obviously a diagnosis that someone would receive having had a panic attack, but it is a specifier. The difference in DSM-IV now is that the panic attack specifier can be used across the board. It's not limited to panic disorder. It's not limited to agoraphobia. Across the board, a person you could specify as having panic attacks without regard to what their diagnosis is. I think it's a real benefit within the DSM-IV. There's also a difference in terms of how panic attack is described. In DSM-IV, it was described as a discrete period of intense fear or intense discomfort. Okay? And that was a source of confusion for many clinicians because discrete period implies that when the panic attack ends is of diagnostic importance. And that's not the case. For panic attacks, what's most important is the way in which it comes on, not how long it lasts, and not what the course is after it started. And I think in DSM-V, they do a very nice job of highlighting the fact that it has to be an abrupt surge. Okay, it doesn't really matter what happens after that surge starts. It just matters that, bam, this comes on and it happens fast. In DSM-IV, it happened fast. It happened within 10 minutes. That's what the wording in DSM-IV was, within 10 minutes. Now they've gotten rid of the 10, and they've just stated within minutes. I think if we're familiar with panic attacks, they generally don't take 5 minutes to reach, or excuse me, 10 minutes to reach their peak. It usually happens either immediately or certainly within 2 or 3 minutes. The idea here is that this happens within a few minutes. Okay? That's not explicitly stated in the criterion, but it is explicitly stated later on in the section in the DSM-V if you were to read it. During which time, okay, so an abrupt surge, during which time 4 or more of the following symptoms occur. Okay. Heart palpitations, sweating, trembling, shortness of breath, feelings of choking, chest pain, nausea, feeling dizzy, chills or heat sensations, numbness or tingling, derealization or depersonalization, a fear of losing control, or a fear of dying. These are all the same from DSM-IV. Okay. With the exception of number 9, you'll see number 9 has an asterisk. That used to be hot flushes. Hot flushes has been changed to heat sensations. Okay, moving from panic attacks to panic disorder. By the way, in DSM-V, panic disorder actually occurs before panic attacks, but for reasons of organization, I felt it made the most sense for me to introduce panic attacks first here. I'm not exactly sure why the order is the way that it is in the book. For panic disorder, by and large, the criteria are the same between DSM-V and DSM-IV. Recurrent, unexpected panic attacks. Remember, these unexpected panic attacks need to be recurrent. Having had one unexpected panic attack is not enough to meet criteria for the disorder. These unexpected panic attacks could be nocturnal as well. Just a couple things to keep in mind. So recurrent, unexpected, out-of-the-blue panic attacks, we sometimes say, with at least 1 month or more, okay, of one or both of the following: concern about the attacks, or a maladaptive change in behavior or avoidance due to the attacks. Okay? Criterion B in DSM-IV used to have to do with agoraphobia. Okay? Now agoraphobia is its own animal, and so it's no longer included in anything having to do with panic disorder. So you'll diagnose panic disorder without any regard at all about a person's agoraphobic behaviors. The panic attacks are not due to a substance, not due to a medication, not due to a medical condition, and they're not better explained by another mental disorder. Moving into agoraphobia. This is one of the biggest changes between DSM-IV and DSM-V, is the fact that we've teased apart panic disorder and agoraphobia, and now agoraphobia is its own standalone codable disorder. Has nothing to do with panic disorder any longer. By and large, agoraphobia remains the way that it was in DSM-IV, the way that we thought about it. It's just now independent. Okay. There's a subtle change in emphasis, though, with regard to criterion A. Criterion A used to be what the fear was about. Okay. It was that escape would be difficult, or they wouldn't be able to get help, etc. But now the emphasis initially is shifted towards where does the fear happen? Where does the anxiety happen? It must be in 2 or more of these 5 situations. Okay? Using public transportation, being in open spaces, enclosed spaces is now the wording, standing in line or being in a crowd, or being outside of the home alone. By and large, these are the same types of spots in which we would consider people having experienced agoraphobia in the past. Subtle changes is the third. Being in enclosed spaces. Being in enclosed spaces was never referenced in DSM-IV. However, shops, theaters, and cinemas were all sort of prototypical places in which an agoraphobic person would be tremendously uncomfortable. So the place is not new, but the way it's considered by the DSM-V is new. I think in DSM-IV we considered shops, theaters, and cinemas to be being in a crowd. Okay. Still with agoraphobia on the next slide, the person avoids these places because escape would be difficult or help might not be available. Okay, that's exactly the same thing. Keep in mind the second part of that criterion. In the event of developing either panic-like symptoms or other incapacitating or embarrassing symptoms. So they might be scared or anxious for another non-panic reason and evidence agoraphobic symptoms. Now, if the symptoms are sufficiently severe, distressing, and impairing, they could still meet criteria without regard to panic or fears of panic. The moving to C, the agoraphobic situations almost always provoke fear or anxiety, and the situation is actively avoided, require the presence of a companion, or are endured with intense fear or anxiety. Finally, this is the last agoraphobia slide. The fear or anxiety is out of proportion. Again, the clinical judgment comes into play with criterion E, and it doesn't fit sociocultural context. Typically lasting 6 months or more, and then distress, impairment, and if another medical condition exists, the symptoms are excessive. GAD, that will be relieving. This is exactly the same as it was before. There's not too much to think about when it comes to GAD between DSM-V and DSM-IV. Criterion A is the same, B and C are the same, and then we jump and we have the list of symptoms that we associate with GAD: restlessness, feeling keyed up or on edge, fatigue, difficulty concentrating, irritability, muscle tension, and sleep disturbances. Precisely the same list of symptoms that was included in DSM-IV. Now there is a change on this page when it comes to GAD, but it's minor. In DSM-IV, criterion D also referenced not limited to worry about another axis 1 disorder. That's been dropped. I'm not exactly sure why that's been dropped. My sense is that by and large, that issue subsumed in F, criterion F at the bottom of this slide, that it's not better explained by another mental disorder, and that if the worry or preoccupation was limited or exclusively about another mental disorder, it would obviously be better explained by that mental disorder. So I think it was a redundancy, and it's been eliminated. Okay, so this is a new name. Okay, it used to be called substance-induced. Now it's called substance or medication-induced. Greater appreciation that medications could inadvertently induce an anxiety disorder. The criterion here is largely the same, panic attack, criterion A rather. Panic attacks or anxiety is a predominant feature in the clinical picture. Okay. In DSM-IV, this included a brief phrase about obsessive-compulsive symptoms. That's been left out in DSM-V, presumably because obsessive-compulsive disorder now resides in its own section. So they've taken that clause out and it's included there. So now we're looking about panic attacks or anxiety is the predominant feature. Okay. Criterion B, there's evidence from the history, from the physical examination, or from the lab, okay, that both 1 and 2 are the case. The symptoms developed during or soon after the exposure to the substance or to the medication, and that the involved substance, right, the hypothetically etiological factor, is capable of producing the symptoms. In DSM-IV, for some unknown reason to me, it was or. It was either 1 or 2. Now it's both 1 and 2. How we can make a diagnosis of substance-induced anxiety disorder when the substance at question isn't capable of producing the symptoms, that one's beyond me. But now that's been cleaned up and it's a little bit more straightforward. It makes a lot more intuitive sense. Staying with substance and medication-induced anxiety disorder, okay, it's not better explained by a different anxiety disorder. Okay. I'll let you read this section here. So it's basically stating that the correlation between the substance or the medication and the anxiety presentation has to be strong. There shouldn't be exceptions where the anxiety was present in the absence of the substance or of the medication. Criterion D, it's not happening exclusively during the course of the delirium, and it's causing clinically significant distress or impairment. Okay. There are a few specifiers here. One was the onset of the disturbance while they were intoxicated on the substance or by the medication. Was it during a period of withdrawal? This is after the onset of medication use. Formerly, there was another set, a second set of specifiers for substance-induced anxiety disorder, had to do with characterizing the nature of the symptoms. Were they kind of generalized anxiety-like, were they panic-like, or were they obsessive-compulsive-like? Those have been left out of the diagnosis for DSM-V and will no longer be specified. Moving along. Here we have anxiety disorder due to another medical condition. This is another case in which the wording has been changed ever so slightly between DSM-IV and DSM-V to highlight the biological contributions to mental health problems. It used to be due to a general medical condition. Now it's due to another medical condition. Okay. Panic attacks or anxiety is predominant in the clinical picture. Again, in DSM-IV, this used to include a clause about obsessive-compulsive symptoms that's been left out because OCD is no longer considered an anxiety disorder. B, that there's evidence from the history, from an exam, or from the lab that the disturbance is a direct result, okay, of the medical condition. It's not better explained by another disorder. It's not occurring exclusively during a delirium, and it results in clinically significant distress or an impairment. Okay, then if we think back to DSM-IV, okay, we had anxiety disorder NOS, not otherwise specified, and it would incorporate a whole host of things that didn't precisely fit the requirements for the other diagnoses. Now, anxiety disorder NOS has been separated into 2 separate diagnoses, which I think will be tremendously helpful. The first is other specified anxiety disorder. Okay? So judging by the name, you can tell we're judging someone with an anxiety disorder that wasn't formally listed, okay? But we're specifying the nature of the anxiety and why they don't meet criteria for another disorder. Okay? So if we look at the top, symptoms are characteristic and distressing and impairing, but full criteria are not met. So if someone is very, very close to meeting agoraphobia or very, very close to meeting GAD, okay, you would give them other specified anxiety disorder, specify what their symptoms are, how close they are to a different disorder, and why you're not giving them that disorder. An example might be if someone's having limited symptom attacks, right? They might be only having 3 of the symptoms of a panic attack, okay? They might be having, down at the bottom, a couple atypical symptoms of panic attacks to not meet full criteria for panic disorder for panic attacks. Or generalized anxiety maybe not occurring more days than not, and so they're close, but they're not quite there, and you want to specify exactly where they are. Because it's a close fit, but it's not a perfect fit. And then finally, we have unspecified anxiety disorder. Okay, unspecified anxiety disorder is similar to the one we just covered, but a person would not be listing in as much detail what the symptoms are, what the diagnoses that they're close to are, why they're not giving them full criteria for a certain disorder. This would usually be the case when the symptoms are characteristic, they're distressed, they're impaired, but for whatever reason it doesn't seem to fit, but the person doesn't either have time or expertise or the knowledge to specify exactly what the situation is or why it doesn't fit. Okay. I think the best example is in an emergency department where someone might be doing a clinical evaluation, doesn't have expertise in anxiety or anxiety disorders or mental health disorders for that matter. The person is very anxious or is panicky, and so almost as a placeholder they could get this diagnosis until they move on or are triaged or seen by someone with a little bit more expertise or more time on their side. So again, anxiety disorder, NOS, has been separated into 2 categories. One, specified anxiety, other specified anxiety disorder, and unspecified anxiety disorder. And I think that's a step in the right direction. I think we're getting very, very close to wrapping up. That's exactly right. That takes us through the entirety of the talk. Okay, primary references for the talk were obviously the DSM-IV itself, and then through the American Psychiatric Association, a few other documents. Okay, I would encourage you to take a look at both and review them for a little bit greater understanding. And if you want to get more into the readings about the debate about why the changes were made, why, for instance, why PTSD is no longer included, why OCD is no longer included, I would highly encourage you to do so. It's a fascinating topic. We just don't have time for it right now. Okay. And again, don't forget to peruse the websites, the APA, or specifically the DSM-IV for a little bit more information and for further reading. Thank you so much for your time, and thanks again to Valent.